Hello, and welcome to the Dementia Capable webinar series provided by the Rosalind Carter Institute for Caregiving in partnership with the Georgia Division on Aging Services. Before getting started, we advise having a pen and paper ready to write down any information and links to the resources as they are provided. Otherwise, you will have to view the webinar again to retrieve it later. You may pause the webinar now if needed. Remember that the link to the SurveyMonkey post-test will be pasted onto the last slide. The post-test will remain open for an indefinite amount of time. Please take it at your earliest convenience, though we encourage immediately following the webinar. A certificate can be provided when entering your email address at the end of the post-test. Today's webinar will be Impact of Stages on Caregiver Experience, presented by Dr. Ellen Cotter. Ellen Cotter has a BA in psychology from the University of Virginia and an MA and PhD in developmental psychology from the University of Alabama at Birmingham. She is a professor of psychology in the Department of Psychology and Sociology at Georgia Southwestern State University. She regularly teaches courses on topics related to lifespan development, caregiving, and psychological aspects of language. Her research interests include the scholarship of teaching and learning, critical thinking, and caregiving. Welcome, Dr. Cotter.
Thank you for having me. Thank you for having me, and thank you everybody who is listening to this, and I hope that you're having a good day no matter where you are. As Elizabeth said, the topic for today is the impact of stages on caregiver experience. And the order that we are going to go in today is we're first going to talk a little bit about some changes in the brain and the effects that these changes have on people with dementia. And this is useful because depending on exactly what's going on in a person's brain, we'll see different types of symptoms. And that can be useful for helping to figure out what stage of dementia that somebody's in, because there are several different types of dementia and they don't all take the same progression. And for example, sometimes you'll hear people say, oh, dementia, behavior problems are common in the middle stages of dementia. Well, not always, and that's why we'll talk a little bit about that. We'll also talk a little bit about how stages are assessed, and I've got some examples of some dementia screening instruments in here, as well as some stage-specific information in terms of, in general, what kinds of issues are likely to come up at different stages of dementia. And then we'll talk a little bit about some overall conclusions. So first of all, just to make sure everybody's on the same page with all of this, the word dementia refers to a group of conditions that all have similar features to them. Just like the word cancer refers to a bunch of different conditions located in different parts of the body, but they all involve sort of the same underlying process. With dementia, dementia, no matter what type we're dealing with, is a progressive condition, which in a medical context means it gets worse over time. And the progressive nature of this means that, that as the dementia continues, as the disease process takes hold, different things are going to be affected, particularly cognitively. And the three main things we think of in terms of cognitive functions that get affected in dementia are memory, language, and judgment. We may see other things as well, and we'll talk about that later. In addition to cognitive changes, we also see in people with dementia changes in behavior. And behavior here is used kind of broadly. We see changes in self-care abilities. As dementia progresses, people will lose the ability to care for themselves in terms of daily activities like bathing and dressing and grooming, and also with other self-care types of activities like knowing when to take medications and taking them properly, being able to drive, shop, clean the house, things like that. Another aspect of behavior that might get affected with dementia is appropriate behavior, and sometimes people with dementia develop behavior problems, sometimes just embarrassing ones, sometimes potentially dangerous ones, wandering away from home, being aggressive, overeating, public swearing, things like that. So we sometimes see that. And we also are likely to see changes in personality. For example, I've known people who were outgoing when they were younger, very outgoing and extroverted and enjoyed interacting with people. And then after they developed dementia, they stopped enjoying that because interacting with people became hard for them. And so their personality changed from being extroverted to more introverted. And we might see things like that, as well as changes like the development of kind of paranoid and suspicious behavior. So we might see those as well. So the question is, why do these changes happen? And again, for the sake of making sure we're all on the same page, your brain is responsible for everything you do. Even functions in your body like controlling your heart rate and your breathing and your blood pressure are at least partially controlled by the workings of your brain. And so as we have changes in the brain, we have changes in thinking and behavior that result from those changes in the brain. And as I mentioned before, there are different types of dementia. And these different types of dementia have not only different changes in the brain that occur, but they also have different symptoms and different patterns of decline. So we look for different things to sort of tell us what we're dealing with in terms of what type of dementia is this, what stage are we at, what's the prognosis, what's coming next. We'll talk first about Alzheimer's disease because it appears to be the most common form of dementia. The brain changes in Alzheimer's disease take a couple of different forms. One form is what we call neuritic plaques. These are places in the brain where there is a buildup of a substance called amyloid protein. And amyloid protein is a substance that actually occurs normally in the brain, but what it's not supposed to do is it's not supposed to build up in sticky little pools inside the brain, and that's what it does in people with Alzheimer's disease. We also see what are called neurofibrillary tangles, which are deteriorations of the nerve cells or neurons in the brain. And in fact, the structure of the neuron just kind of falls apart. And I'll show a picture in a moment of what this sort of looks like. The plaques and tangles affect how neurons communicate, and the only way our brain works is if our neurons can communicate with each other. Just like a network of telephones or computers, the only way that we can send email to other people is if our computer's working okay and their computer's working okay and the lines between them are working okay. It's like that in the brain. The only way that the different parts of our brain can communicate and help us function are if the neurons that are in our brain are actually working well. We also see another change in people with Alzheimer's disease, which is the atrophy or death of brain tissue. This is not specific to Alzheimer's disease. The plaques and tangles are. Those are very specific to Alzheimer's disease. Death of brain tissue, however, is not specific to Alzheimer's disease and can occur in other types of dementia as well. So even though we see that there, that's not a unique indicator. And here we see some visual representation of these brain changes. The picture on the left is a drawing. It's not an actual medical photograph. But it gives you sort of an idea of what these plaques and tangles look like. So in the left picture, on the left of that picture, you see a healthy neuron and then a diseased neuron. And you can kind of tell which one's which. One looks nicer than the other. So you can see in the right-hand side of the picture, You can see the diseased neuron. The main body of the neuron looks like it's been kind of taken over by something. This is a plaque that's kind of taken hold of the neuron and is preventing it from functioning. And then in the little chain of little yellow blobs that are coming away from it, this is a part of the neuron called the axon, and it's where information leaves the neuron to go to another neuron. You can see where it appears to be kind of falling apart. There are chunks taken out of it. And what these two things will do is, like I said, prevent the neurons from communicating effectively. On the right side, up at the top, you can see an actual photograph of brain tissue. And this is an angle there where if you were looking at a person straight on and you were to, facing them, and you were to take a section out of their brain looking straight on, just like a flat slide that way, this is what you would see. And on the left you can see a healthy brain, and on the right you can see the brain of someone with severe Alzheimer's disease. And this is where you can see the death of brain tissue. You can see that the one on the right is a lot smaller. It has less tissue in it. It's less compact. There's more spaces in there. And this is where brain tissue has died. At the bottom we can see the results of PET scans, which are scans of brain activity. And in PET scans, red and yellow areas show areas of high activity, and blue and purple areas show areas of low activity. And on the left you see the PET scan of someone with a healthy brain, and on the right you see the PET scan of someone with a diseased brain, with someone with dementia. And you can see that the one on the left obviously has a lot more areas of red and yellow, which means there's a lot more activity going on in that brain. We don't know what that person's doing. Maybe they're reading a story, maybe they're singing a song, maybe they're looking at pictures and thinking about what the pictures mean. We don't know what they were asked to do at that point. But we can see that there's a lot going on. Whereas on the right-hand side, we see a lot more areas of blue and purple, which indicates not much brain activity, which is again probably caused by the loss of brain tissue and the lack of communicative ability between the neurons in the brain. Going back to what Alzheimer's disease does, the changes in Alzheimer's disease start initially in the parts of the brain related to memory, and this is why for most people memory loss is the first symptom of Alzheimer's disease. Later on, we're likely to see these changes that are having a negative impact on memory spread to other parts of the brain that control other things, such as judgment, the ability to make good decisions, such as the ability to use and understand language, and the ability to control actions and behavior. So this is kind of what we see there. The changes start out in memory areas, and then they move on into other parts of the brain. And this is why in people with Alzheimer's disease, memory goes first, and then other things that are also related to memory tend to become more problematic later on. Let's talk about other dementias for a moment because, as I mentioned before, kind of understanding what stage of the dementia process somebody's in does involve, to some extent, knowing exactly what they're dealing with. Some form of dementias are actually potentially reversible. People who have problems with their thyroid, people who have vitamin deficiencies, people who have certain types of infections, even just things like a urinary tract infection, can show symptoms like dementia. And the good news with those is that those are often very treatable, and once you fix the thyroid problem or get some B12 or clear up the UTI, everything goes back to normal, and that's good when that happens. In terms of non-reversible dementias, Alzheimer's disease is one of those. Another form of non-reversible dementia is what we call vascular dementia. This is caused when blood flow to the brain gets interrupted, and it usually through either a stroke or what's called a TIA, a transient ischemic attack. We call it a stroke if the interruption in blood flow happens in a major blood vessel, and if it happens in smaller blood vessels, we tend to call it a TIA. These can happen in any part of the brain, so exactly what is affected by a stroke or a TIA is kind of unpredictable unless you know exactly where the person had their stroke. But the one thing that is kind of common across that is that in cases of vascular dementia, there's usually a sudden noticeable decline in a person's functioning. In Alzheimer's disease, the path of decline is often very gradual, and it might be hard to pinpoint exactly when anything started. But with vascular dementia, it's often a little easier to figure that out. And the change may be big if the person had an actual stroke, or maybe small if they had a TIA. Another type of dementia is what's called frontotemporal dementia, and this is a type of dementia that it initially starts in a different part of the brain than Alzheimer's disease. It starts in the frontal lobes, which is the part of your brain that's kind of behind your forehead. If you put your hand on your forehead, what's behind it are the frontal lobes of your brain. And the frontal lobes are very important for things like controlling behavior, making good decisions, planning and organizing, controlling your temper, knowing that it's not appropriate to tell someone they're ugly, even if you think they are. Those are things that your frontal lobes help with. And in frontotemporal dementia, the frontal lobes tend to deteriorate first, and then the temporal lobes, which if you put your hands on your ears, your temporal lobes are sort of behind your ears there. The temporal lobes are more involved in memory. So in Alzheimer's disease, what you typically see is memory loss happens first, and then personality and behavior changes happen later on. If you're dealing with frontotemporal dementia, you're more likely to have a situation where the personality and behavior changes happen first, and then the memory loss happens later, and it's just because there are different parts of the brain involved. So again, if you hear somebody say, oh, well, behavior changes and behavior problems are part of the middle stage of dementia, that's really not true for all types. And so knowing what type of dementia you're dealing with is important for understanding that. Two other conditions that we can talk about, and we talk about them together because they're sort of related, are Parkinson's disease and something called dementia with Lewy bodies. And these types of dementia both involve impairment of movement as well as cognitive functioning. And that's easy to think of when we think of Parkinson's disease. We think of Parkinson's disease, we think of shaking, difficulty walking, difficulty moving. We think of Michael J. Fox. We think of Muhammad Ali lighting the Olympic torch. We think of those types of things. And what happens with Parkinson's disease and dementia with Lewy bodies, the primary part of the brain that's affected are parts of the brain that are involved in controlling movement. And so the first changes we typically see in this case are likely to be motor-based, and then the cognitive changes come later. And however, if the motor impairment, and this is what it says on the slide, if the motor impairment comes significantly before the behavior and cognitive changes, what you're most likely dealing with is Parkinson's disease. If, however, you have either memory problems coming at the same time as or before the development of tremors and shaking and the movement disorders, then you might be dealing with dementia with Lewy bodies. So that's what we see there. Something else that's worth talking about that is not a type of dementia per se, but you might still encounter this term or know people who have it, is mild cognitive impairment. This is something that is kind of a middle ground between kind of typical healthy aging, which does involve some memory loss and a little bit of slowness of cognitive functioning, senior moments and stuff like that. Everybody experiences that. Um, and so, but there's a middle ground between that and actual dementia, and that middle ground is what we call mild cognitive impairment. So people with mild cognitive impairment will have noticeable cognitive changes. They don't function exactly the way they did when they were younger. But there won't be a major impact on daily functioning. And if there is a progression, it's usually very mild or potentially even non-existent. People with mild cognitive impairment do appear to have an increased chance of developing dementia, but this is not a guarantee. This mild cognitive impairment does not always lead to dementia. It does not appear to be a cause of dementia. This is it's a risk factor, but it's not the only one, and it's not a guarantee. So you may see people who fall into this category as well, and it may be hard initially to tell, is this person in the very mild stages of dementia or the very early stages of dementia, or do they just have mild cognitive impairment? So that's kind of a decision point that needs to be talked about with a healthcare provider on that front. One thing that sometimes comes up when we talk about the stages of dementia, and in particular for a lot of people with Alzheimer's disease, how will medication help the progression of Alzheimer's disease and the experience of those different stages? There are a couple of different ways we can approach the issue of medication. There are certain medications such as Aricept and Namenda and some other things that are used specifically to treat dementia. And what these medications do is they affect how the brain uses chemicals that are involved in brain function. Your brain works on chemicals. So medications that help treat depression, anxiety, dementia, things like that, they all monitor or modify the chemicals that are in the brain. And medications for dementia focus specifically on chemicals that help us think and process information. What medications like Aricept and Namenda do is they tend to slow down the rate of progression so that people might spend more time in the early stages of Alzheimer's disease as opposed to progressing more rapidly to the middle and late stages. But these medications don't reverse or stop the disease process. So that's one thing that sometimes caregivers are disappointed about is they think that it's going to make things all better or at least prevent it from getting worse. And that really is not what typically happens. Also, medications for treatment of dementia symptoms are best for people with mild to moderate impairment. So the early stages tend to be the best time to use that, and you'll get the best results for that. There are other types of medications as well that might be relevant for treatment of people with dementia. For example, if you have someone with high blood pressure who has either had a stroke or is at risk for having a stroke, medications for treating the high blood pressure may help prevent dementia by preventing strokes. This is very useful. We would like to not have dementia develop at all if we can possibly help it. And again, if there are certain types of conditions producing problems, again, such as an underactive thyroid, we can take medications to help regulate the thyroid, and that fixes the problem that's producing the dementia. There are medications that help control the movement problems in people with Parkinson's disease and dementia with Lewy bodies, and again, they may have some effect on cognitive functioning too. And also medications can help caregivers and their loved ones manage behavior and mood. Sometimes people with dementia are very scared and anxious because they don't worry about what's going to happen to them, or they don't understand what's going on around them, and the world is kind of a scary and unpleasant place. And so medications can sometimes help with those types of things. But with those types of situations, it's really a good idea to try non-pharmaceutical strategies first. We would much rather have a person comfortable in their home and not relying on sedatives to have a happy day. We would much rather try to do things to structure their home environment so that it's less intimidating and less confusing and less scary, rather than just stuffing them full of pills so that they sit there quietly. We would much rather have that happen. So getting into the issue of stages, we're kind of switching gears a little bit here. Why we care about stages at all is that stages are potentially useful. They can be useful in that they can help caregivers get kind of a realistic appraisal of their situation, or in some cases even a validation of what they've been noticing. If you are convinced that your loved one is having some kind of dementia problem and you go to the doctor and the doctor says, oh yes, we think that your loved one is in the early stages of Alzheimer's disease, that doesn't necessarily make you feel better because you've just gotten terrible news, but at least you know that you were right, that you made a good decision there to notice something and do something about it and look into it. And that can be useful for helping people feel like, okay, it's not just me, I'm not just being difficult, I'm not just looking for problems that aren't really there. And also, again, you can get a realistic appraisal of, okay, this person has dementia. Okay, I need to make some changes in the way that I'm doing things and the way that I expect them to do things as well. Knowing about stages can help caregivers anticipate changes. They can also help caregivers recognize not only the difficulties and challenges that a person is likely to have, but also the skills that are likely to be maintained, which is something we don't emphasize enough. And I'm probably not going to emphasize it enough here today either. But we don't always emphasize what the person is still able to do. We focus a lot on losses, but not on what's maintained. And there are certain things that will be maintained until fairly late in the disease process. Memories for really well-learned childhood tasks such as playing a musical instrument can be maintained until fairly late in the disease process. The ability to read for people who know how to read is also maintained until fairly late, surprisingly sometimes. Knowing what stage someone's in can also help with making appropriate arrangements. If we know that someone is in the early stages of Alzheimer's disease, then if they don't have a will, or if they haven't got a will or power of attorney or living will that's been updated in a while, this might be a good time to do that before their impairment gets so bad that it becomes a very complicated process. And also knowing what stage someone is in can help caregivers convey to other people and for other people to understand how they can help. One of the things that's challenging sometimes when we're dealing with a serious illness is knowing what to do to help the people that we care about. If your neighbor is in the early stages of dementia or the middle stages of dementia, you may have some ideas for what you can do to help out with that, to make their life and their caregiver's life easier. On the other hand, stages can also pose some challenges, and one of these challenges is that stages do not look the same for everybody. One thing that makes a big difference in the experience of stages is that the time of onset of dementia does not always correspond to the time of diagnosis. In Alzheimer's disease, for example, people may have been having memory problems for years before it's really diagnosed as anything official. And so when you have to pinpoint, well, when exactly did the person develop this, it may be hard to tell, especially if the person has always been sort of absent-minded and forgetful. This may just feel like more of the same. And so thinking, oh, okay, well, the early stage of Alzheimer's disease lasts for this length of time, and they just got diagnosed, so they have that length of time left in the early stage, might be kind of misleading because you don't always know how long things have been going on beforehand. So caregivers who think, oh, well, the early stage lasts this length, and I've got that much time, you may not actually. Also, different conditions, as we've kind of talked about, have different symptoms and patterns of impairment. And so, again, looking only at one perception of here's what the different stages of dementia are may not fit every single case of dementia out there. On a different note, the very existence of stages, the very fact that dementia is a progressive illness that is going to change over time and get worse over time, means that caregivers have to engage in a pretty constant process of readjustment and adaptation. Even within stages, care recipients will have good days and bad days. The days can be fairly unpredictable a lot of times. And so even from day to day, there's a readjustment period and the need for adaptation. And when we think about this happening kind of on a broader scale, in the sense that 3 years from now things might be different than they are now, we can see kind of how that plays out on a larger long-term scale. Knowing about different stages can cause caregivers and care recipients as well to really dread what's coming up. If they know, oh, well, this is what the late stages of dementia looks like for someone with this condition, that can cause them to get very scared and very depressed thinking about what's coming up. They know that it's going to not stay good forever and that things are going to get really difficult. And on one level, that can help people be prepared, but on the other hand, it can also help people, or not help people, but it can also cause people to become very upset and distressed thinking about that. And this can also turn into what we call anticipatory grief, which is essentially grieving for the loss of something that hasn't quite happened yet. We grieve a person when they die, but for people with dementia and their loved ones, they have a grieving process too that takes place before the death of the person with dementia. You grieve the loss of the life that you had and the companionship that you had. The people with dementia themselves may grieve the loss of their independence and the friendships that they had, and they're feeling that they're themselves. So again, knowing what's coming up can kind of cause that to happen, and that's something to be mindful of. When we look at how stages are assessed, there are several different instruments out there that can be used to measure the stages of progression in Alzheimer's disease and other dementias. And they're not necessarily interchangeable, so that's one thing to keep in mind. And if you look online, you can see examples of different instruments used to stage dementias. But again, I've got an example coming up. But when we look at stages of functioning, a lot of times one thing that happens is we tend to focus very heavily on the cognitive functioning. Here are the types of memory problems a person's going to have. Here are the types of things the person is going to have difficulty recalling, or tasks they're going to have difficulty performing. But we also really need to look at other things. We need to look at how the person is functioning socially. Can they still hold conversations? Do they still enjoy being around others, assuming that they did in the first place? Are they able to participate in self-care and household activities? Maybe not to the extent that they used to be able to do, but are they still able to do things? And if so, what is that, and how can we use that to our advantage to keep people busy and happy? And also, let's look at behavior as well. Are there behavior problems? What does this tell us about the likely memory impairments that are going on? If your loved one is calling the police saying that they've been kidnapped, that's and trying to wander away from home, that's showing signs that they're probably not recognizing their family members in their home anymore. And so that kind of tells us where a person might be in terms of how much cognitive impairment is going on. So this is a really long slide, and don't necessarily try to write down everything that's on it, but this is just an example of a dementia screening tool called the FAST, the Functional Assessment Staging. And what you see at the very top, you'll see it's got 7 different stages, ranging from normal adult, which, that's kind of an interesting concept anyway, down to severe Alzheimer's. And one thing that I find interesting about the FAST is that it distinguishes between a normal adult and a normal older adult. And that's actually kind of useful to know because, as we mentioned before, there's a certain amount of cognitive changes that aren't typical as we age and to be expected. And, recognizing that that's happening and that that's okay is really, part of the process of adapting successfully to getting older. So I actually really like that this one includes the distinction between quote-unquote normal adult and quote-unquote normal older adult. And then we can see that it progresses. Now, the language that this instrument uses is specific to Alzheimer's disease. You can see that in the different stages it's there. How well would this apply to people with other forms of dementia, such as frontotemporal dementia or vascular dementia? That's a really good question. And that's something to keep in mind is that if a particular assessment tool for staging dementia uses language that's specific to Alzheimer's disease, that might not necessarily be the best one to use if we're not completely sure that's what the person has. But getting back to this, this particular tool focuses not so much on cognitive limitations, but on functional limitations, which is actually really useful. And so this talks about, here's where the person is likely to require assistance. Here are the types of challenges that are likely to come up. And these are things that are very practical and things that caregivers are likely to notice on a daily basis, such as if you look at stage 6, titled Moderately Severe Alzheimer's, assistance needed for dressing and bathing and toileting, experiencing incontinence. That kind of tells you a little bit about if you're at that point, you say, okay, well that's kind of what I'm dealing with, as opposed to you can say, well, no, we're not at that point yet. We're dealing with other problems right now. So this is the kind of thing that you might see with some things. And one thing again, as I mentioned before, it's important to think about skills that are maintained. We don't really see a lot of that here. This focuses a lot on losses and deficits and needs. So that's something else to think about. This slide and the next slide are examples of stages from something called the Clinical Dementia Rating Scale, or the CDR. And what we have here is a different way of staging dementia. And this one is not using language specific to Alzheimer's disease. And it goes in a little more detail about the types of things that a person may have difficulty with, particularly cognitively. So if you look down at where it says CDR1 mild, it talks about memory loss, and it talks about the idea that recent events and solving problems, which are cognitive, memory for recent events and solving problems, which are cognitive functions, are likely to be impaired. Having difficulty functioning independently at community affairs. So, perhaps we've gone to the movies and we need someone to go to the restroom with us to make sure that we take care of that appropriately and can find our way back to where we need to be, so we don't end up in the wrong movie with people we don't know. and also difficulty with daily activities and hobbies. So the CDR is different from the FAST in that it's got, as you'll see on the next slide, it's got fewer stages. It's also less specific to Alzheimer's disease. It gives a little more detail, and it focuses a little more heavily on cognitive functioning and not just behavioral and functional abilities. Here we also see, if you look up at the top at the first two categories, there's a distinction between no dementia and the CDR 0.5 mild is probably going to be very similar to this idea of mild cognitive impairment that I talked about earlier, where we don't, daily life might be very slightly impaired, but not to the extent that anything really needs to happen with that. Whereas the CDR1 mild probably is getting into more dementia-type territory. On the next slide is the other two categories that come from that. And again, we can see a progression, moderate and severe, and we're again focusing a lot on memory functioning and how the memory functioning and changes in that are affecting other things, such as the ability to engage in tasks and perform chores, engage in personal care, and things like that. There are other rating scales and instruments used to score dementia, and some of them are even more elaborate than this. But we're just kind of looking at these two as a way to get a sense of some of the information that might be provided. And for caregivers who are told that their loved one has a diagnosis of dementia and that they are in such and such a stage, one nice thing about the internet is you may be able to go out and look up an example of what that instrument is. If your loved one's healthcare provider doesn't show it to you, you can maybe look up what that is and try to see, here are the types of things it's assessing. Now, we all have to be careful about seeking out this type of medical information online if we're not trained professionals, because then, and I do this too, you look up your symptoms for something and you convince yourself that you've got the Ebola virus or something like that, when really all you have is a head cold. And you don't want to get involved in stuff like that. But we can possibly find out that information if we see a test result, if we see a report that says, oh, this is the stage of dementia we think they're in. We can ask, what instrument did you use for that? What are you making that basis on? And then try to, if the healthcare provider doesn't give us that information, we can try looking for it ourselves. But again, we have to be careful with interpreting those types of things. As I mentioned before, getting back to the issue of stages, and one thing you can see from the examples of the FAST and the CDR is the idea that there is progression and that things are going to change over time. This requires, as I mentioned before, a need for caregivers and also to some extent care recipients to cope with that, to adjust to the progression of symptoms and the progression of impairment. And there are some things that we can do to try to help that a little bit, particularly if we are a caregiver or we are trying to support a caregiver. One thing that caregivers sometimes have difficulty with is that they expect things to be the same. They expect that everything is going to be the same, that nothing's going to change, and that everything will be able to kind of continue the way it has been. And this can be a difficult thing to navigate, especially if it involves things about taking away people's independence. We all know people who have let their loved one with dementia drive past the point where it was probably safe because they didn't want to get into an argument about it, or they did get into an argument about it and it was so unpleasant that they just want to try to avoid that situation. Or perhaps the person with dementia is someone who used to make all the financial decisions in the house, and you kind of want to still let them do that, even though you're not really convinced that that's a good thing, but that's the role they've always had. That's the role you're comfortable with, too. But those things may not necessarily be may not necessarily be useful strategies there because it may result in, at the minimum, frustration when people can't do things the way they want to, or other people want them to. And in the case of things like driving and using household appliances and bathing independently, could also be potentially dangerous. So using this idea of stages and the knowledge that things are going to change, and not in a good way, can help us be realistic about not expecting things to stay the same. Coping with progression can also help, again, focusing on strengths and trying to maximize independence when possible. Somebody may not be able to help with laundry or yard work as much as they used to, but there might be something that they can still do, like folding up laundry or matching socks. Maybe not necessarily ironing or mowing the lawn, but perhaps folding clothes, perhaps planting some stuff in the garden, things using the leaf blower, things like that. So trying to maximize independence if possible can be very useful in recognizing what a person can still do as opposed to what they've lost is kind of a key factor for that. And that information may be hard to come by. Also, having routines and familiarity is very beneficial for people with different forms of dementia because it helps keep things predictable. A lot of times, especially in some of the earlier stages of dementia, people will show problems when they're out of their routine, they're out of their familiar environment, they're under stress. And that can be why things go for a while before a diagnosis is made, because when people are we tend to function best in the environments we're comfortable in, and people in the early stages of dementia may structure their lives so that it's comfortable for them, and then we don't realize how much things have progressed until something happens. So that can be something important. Also, coping with progression, and this is especially true as the person's language skills deteriorate, is using good communication. Good communication has a bunch of characteristics, but the two that are really important to note here is that good communication is clear and it's brief. We're not going to use really long sentences. When we, if we've got several things that we want a person to do, I want you to take the can of tomato sauce out of the bag and take it over to the counter and put it on the top shelf in the cabinet, we may need to break that down into several distinct steps. So, first we just take it out of the bag. Okay, great job. Thanks for taking it out of the bag. Now I want you to take it over to the cabinet. Okay, thanks for doing that. Now can you put it up on the top shelf? And then, we've got 3 different steps that are brief as opposed to one long series of steps. With speech being clear, we want to avoid figures of speech. We want to also avoid rhetorical questions. Rhetorical questions are things where you want your loved one to take a bath, but you feel bad for telling them to take a bath. So you say, would you like to take a bath? And then they say no. Well, that doesn't help. Now you've kind of created a situation where there's likely to be an argument because you've asked a rhetorical question. And there's a meaning. The meaning when you say to somebody, would you like to take a bath, the underlying meaning of your question is, you need to take a bath. But someone with dementia may have difficulty understanding that. And so a way to get around that would be to say, I need to take a bath. Do you want to take yours now or after I do? And then you have not necessarily ordered them to take a bath, but you have made it sound like they're taking a bath, but they get to pick whether it's now or later. So that's a way to kind of have communication be a little bit clearer and don't create options when there aren't any, which is a problem that we all have, and then we get misunderstood. And this is true even when we're not dealing with dementia situations. Talking about some stage-specific tasks. When a person is in the early stages of dementia, they and their caregivers will most likely need to get information about treatment options, information about progression, information about choices that need to be made. Um, Establishing a support network will be very important, and however that's done is up to the family involved. Planning for the future is also important. Again, I said before that if people get a dementia diagnosis and there aren't plans in place for living wills or health care issues or financial matters, this might be the time to do that rather than waiting until things progress to the point where the person can't make decisions anymore, because then it gets very complicated. Also, tending to the emotional needs of the care recipient. People, especially with Alzheimer's disease, may very well know what their diagnosis is. In fact, they're often in on it. And many times they're terrified and sad because their life is changing in a huge way, and they are very nervous about that. And so in the early stages of dementia, meeting the emotional needs of the care recipient can be just as important in a lot of ways as meeting the emotional needs of the caregiver. In the middle stages of dementia, we talk about caregivers needing to take on more responsibility, and as the dementia progresses, this will deal with issues like safety and supervision, help with household tasks, including driving, also help with daily care, again, dressing and bathing and grooming. If we're dealing with Alzheimer's disease, we may be dealing with the need to manage behavior problems in the middle stage, but again, as I've said a couple of times before, that's not necessarily the typical pattern for everybody. And notice I'm not giving a specific timeline for how long these different stages last, partly because there's some disagreement about what exactly that timeline is, and also because it depends on the condition that we're dealing with and also when the diagnosis occurred. There is plenty of information out there on the internet about how long do different stages of dementia typically last, and that information's out there, but talking about it in this context would be too confusing because there's too many unknowns there. In the late stages of dementia, caregivers will need to really become pretty adept at recognizing nonverbal communication, especially things that might indicate pain or illness or emotional distress. People in late stages of dementia may lose the ability to communicate very effectively, and so understanding other types of things like facial expressions and actions may be very important for that. Also, taking over self-care, particularly related to bodily functions such as toileting, is going to be important. And also exploring care options, including nursing home placement and possibly hospice, is going to be a factor with that too, because things can, a person with dementia may have a different cause of death at an earlier point in the process, such as if they have a heart attack. But assuming that the dementia progresses to the point where we get into the late stages, we're going to be getting into issues where people have difficulty caring for themselves and eventually getting into the points where you have things like difficulty swallowing and refusing to eat. Then you have to make decisions about, do I want to put in a feeding tube? Is this what we want to do? And so some of those care options will hopefully have been worked out in advance, but if not, then the families will need to be making those types of decisions. So kind of in conclusion with this, what we kind of have going on here is that there are many types of dementia. We most often hear about Alzheimer's disease, but it's important to remember the folks with other stuff going on because they don't always get all the attention and all the wealth of knowledge. There are also many ways of characterizing stages. The FAST and the CDR that we saw both distinguish between different degrees of impairment, but they do so using different language and different emphases, and also different numbers of stages, which is important. We need to, when we look at the stages of people with dementia, we need to consider both cognitive and functional impairment, not just focusing on the cognitive abilities, but also what is the person able to do? What are they doing? How are they getting along with other people? What kinds of things are they doing in their self-care and their daily lives? Remembering strengths and the things that the person can still do and still enjoys is very important. Someone who's always been a sports fan may not be able to remember all the sports trivia that they used to, but they might still enjoy watching a baseball game on TV or even at the ballpark. Someone who's been a lifelong churchgoer may remember many of the hymns that they learned as a child and may still be able to sing them and enjoy listening to them or something like that. Those are things that are nice. And also, being able to adapt and adjust to things that come up, both kind of on a day-to-day basis and being in it for the long haul is kind of a key for that. I'm looking right now, I had not thought about this until this very moment, but I'm looking at a little sticky note that I have on the cabinet above my desk, and it's a quote that one of my favorite teachers said last summer at a presentation I went to. And the quote is, "Heroes are masters of the unpredictable." And when you think about superheroes, oh no, the Joker has taken over Gotham City. What's Batman going to do? Well, Batman wasn't expecting this. Batman's got to jump into action and save the day or whatever. Caregivers are kind of like that too. Caring for someone with a serious illness is an unpredictable situation. And dealing with that unpredictability and making it work, even if it's not perfect, is the name of the game. So I wanted to leave you with that idea. We can all potentially be heroes, which doesn't mean being perfect. It just means making the most of what you've got and what you have to deal with. On the next slide, these are some references. These are the first three are examples of some web-based resources that are just kind of general sources of information to read up on. The very last thing on there where it says the Understanding Dementia MOOC, MOOC is a massively open online class. I think that's what that stands for. This is a free online class that's offered by the University of Tasmania, which is on the other side of the world, in the area of Australia and New Zealand. And this is they have two courses in there. They have the Understanding Dementia class, and there's also one on kind of current research and treatment for dementia. And I've taken this Understanding Dementia class, and it's really interesting in terms of thinking about what's going on with people and what is happening with them and how we can help them and things like that. It's not offered constantly, but if you go to that website, you can get some information about when it's going to be offered. It's completely free. You just have to have internet access in order to be able to see the videos and participate in the discussions and things like that. But that's another possible source of information. And also potentially connecting with other people with similar interests, which goes back to part of that building a support network there. And I think this is where I stop talking.
Well, thank you so much, Dr. Cotter. It was such a pleasure to hear about the impact of stages on the caregiver experience. Just as a reminder to viewers, the link to the post-test is pasted onto this last slide. Please take it at your earliest convenience. A certificate can be provided by entering your email address at the end of the post-test. Please remember to view the other webinars in the Dementia Capable webinar series provided by the Rosalind Carter Institute for Caregiving in partnership with the Georgia Division on Aging Services. Thank you, and we hope that you'll join us again.
Thanks, everybody.